View Report, Key Findings from Deaf Access Enter and View Visits. Introduction. Local Healthwatch across North, Central and East London have been working together on a project to improve deaf inclusion in the work of their organisations and increase the involvement of London's deaf community in the improvement of health and social care services in the capital. A key part of the project was recruiting and training 8 volunteers from the deaf community and training them to be Authorised Representatives for Enter and View visits. The British Deaf Association, the BDA, was a key partner in helping recruit the volunteers. Once trained, the volunteers were keen to get involved and use their new skills. It was decided that Enter and View visits would take place looking at deaf access and pathways through 3 London emergency departments: Queen's Hospital, Romford, University College London, and Newham Hospital. The visits were designed by the volunteers and questions developed that could apply to all 3 hospitals. This was to enable a comparison of the findings. Each visit was conducted by 2 volunteers plus communication support. They were pre-announced, so each hospital was expecting the team, but were not clear of the visit's focus. Structure of visit. Each visit started with the volunteers presenting to the emergency department reception so they could assess ease of communication. This was followed by interviews with key staff and a tour of the facility with further questions. After each visit, a debrief session was held to share findings and gather ideas and recommendations. A full report will be published in due course, and this film summarises the key findings. Queen's Hospital, Romford. The reception desks were accessible and faced directly onto the queue, so deaf people could see when it was their turn to be seen. Receptionists had a communication book with BSL included. That could be used to communicate common messages to patients. Written messages were also used as a communication tool. A vibrating and flashing pager is issued to deaf patients, so they know when they are being called to see the triage nurse. A matron and sister in the emergency department had been trained to BSL Level 2, although there appeared to be little understanding from doctors of what level of communication this would enable. There was an over-reliance on friends and family of deaf patients to facilitate communication. The hospital had piloted video BSL interpreting and was looking at the business case for rolling this communication tool out when access to an interpreter was limited. The TV and information screen in waiting areas did not have subtitles, despite the fact they had the capacity. University College London. Reception was accessible for deaf patients, but no communication support was available, apart from writing notes. The hospital is extending the emergency department to cope with demand, but had not engaged any deaf patients in the consultation on this change. They were interested and eager to learn about how they could improve access for deaf patients. There was an over-reliance on friends and family of deaf patients to facilitate communication. Staff appeared to lack confidence and understanding of how to increase access and service quality for deaf patients. Newham Hospital. The reception desks were completely inaccessible for deaf patients, as the queue did not face the receptionists. As they used verbal instructions to approach the desk, it meant the volunteers were unaware they had been called. It was left to another patient to come over to inform the volunteers it was their turn. Written notes were used as a method of communication at reception. Among nursing and medical staff in the emergency department, there was a lack of understanding of how and where to access BSL support when a deaf patient presented in the department. This is despite the hospital having a communication support unit on site. There was an over-reliance on friends and family of deaf patients to facilitate communication. Staff appeared to lack confidence and understanding of how to increase access and service quality for deaf patients. Key findings. In all three hospitals, there was a worry over the lack of visual fire emergency alarm systems. We are looking into this issue more, as there may be technical or clinical reasons why emergency departments do not have visual alarms. All three hospitals lacked clarity in how to communicate with a deaf patient if referred for an MRI scan. Across all three hospitals, there was a lack of consistent understanding of how to access BSL communication support when required, and an over-reliance on friends and family that is not appropriate. There was also an over-reliance on writing messages, which once past reception is not the best communication method for assessment, diagnosis, and communicating medical information. No statistics are kept across the three trusts visited on deaf patients. They were therefore unable to give accurate figures for the number of patients seen. Recommendations. Recommendations. Number 1. Patient data systems need to be amended to record the number of deaf patients, as well as other equalities monitoring information. Number 2. Each emergency department offers BSL training to frontline reception staff. Number 3. The pager system should be rolled out across all London emergency departments. Number 4. Communication books be developed and shared by NHS trusts and be placed on all reception areas for staff. Number 5. Video interpreting should be enabled in emergency departments, as the nature of assessment and care could mean waiting for a BSL interpreter impacts directly on patient treatment. Number 6. A simple step-by-step guide should be developed for staff at all trusts in how to access communication support. Number 7. Deaf awareness training is offered to employees and/or an online course on the intranet.